LinkedIn, Facebook, or YouTube. Leave the comments leave your question via comment section. And today we are also on a new platform, Twitch. So if you're watching there, please leave your questions. Maria, Mike, good afternoon.
Hey.
How are you? I hope you're well. In good health, that's the most important those days. As I mentioned, we'll answer questions about reinfection as our social media viewers are very interested to hear what we know about it and how we understand it. But before we go into that, maybe we should just remind how COVID-19 spreads in the first place.
Sure, so I can start. Hello, everybody. Yes, so this virus, the SARS-CoV-2 virus, which is the virus that causes COVID-19, the disease, spreads between people. And I say that because there are lots of different ways viruses can spread between people, but this is a respiratory pathogen, and it spreads between people mainly who are in close contact with one another. And what happens is when somebody is infected with this virus, the virus can be expelled or can be released from their mouths and their nose when they cough or they sneeze or they talk, and most notably like when they sing or if they project it out when somebody is in close contact with one another. When we think about transmission, when we think about spread, what we think about here at WHO is not only how it spreads, but when somebody transmits the virus to somebody else during the course of their infection. Can they spread it when they don't have symptoms? Can they spread it when they do have symptoms? And we know they can spread both when they don't have symptoms and when they do, and where transmission occurs. And that's the setting. And the setting is really important because depending on where you are, if you're in close contact with someone, if you're in contact with someone for long periods of time, if it's that intensity of exposure, the duration of exposure will increase the likelihood of transmitting between individuals. So we like to think of the how, when, and where the virus transmits. And so these particles that are released from an individual's mouth, some of those particles they're all small, but some of those are a little bit bigger called droplets, and some of those are smaller called aerosols. The droplets can, because they're heavier, because they have more liquid, they can fall quicker to the ground. And if they're aerosols, then they can remain suspended in the air a little bit longer. And if there's viruses in those particles, and if you're in close contact with someone else, you can have that virus transmit to somebody else, either through it being breathed in or if it enters your eyes or your nose or your mouth. But the good news is that there are so many different ways that we can prevent the virus from spreading between people. And everything that we know about transmission to date is fed into our guidance and into our advice to people to prevent that from happening.
Thank you, Maria.
Maybe I could just supplement there, because just again, when we talk about the different viruses and diseases and their transmission patterns, because COVID is one, it's a SARS virus, a coronavirus, but there are other viruses that people know very well. So if we look at something like Ebola virus, which really just transmits at very close contact, and that's considered to be contact-driven disease, the R0 for that, the reproductive number, is usually between 1 and 2. Usually one case generates 1 to 2 other cases. And you've seen how that can generate large outbreaks very, very quickly, even though the period between infections is much longer than in COVID. It can generate outbreaks quickly. If we look at very transmissible diseases, and they will be considered to be aerosol transmitted, there are, as you said, bigger particles, droplets that are really transmitted at closer quarters. Diseases like influenza, diseases like TB and others are seen to be transmitted in that way. There are zeros. The number of people one person infects is usually somewhere between 1.5 and 3 or 4 or 5. In other words, one case can generate 2, 3, 4 or 5 other cases through that mode of transmission. For the aerosol transmitted diseases, the two we have on the human side are measles and chickenpox. And in general, with those diseases, one case can generate anything between 8 and 20 other cases. They're highly transmissible. They spread like wildfire in a susceptible human population. So I think what we see probably in the COVID situation is a mixed pattern of those 3 types of transmission. We're seeing contact type transmission where surfaces can be contaminated and people can pick it up off a surface. We're seeing droplet spread where people are directly contaminated close together. And then we're seeing some of that aerosol spread. And as Maria said, particularly in environments in which that aerosol type transmission can be promoted. Closed, unventilated spaces, lots of people for a long time engaged in activities like singing or exercising, where people are generating these kinds of aerosols. And we've certainly seen that. And we saw that in SARS. We saw elements, we saw superclusters in SARS, like at the Metropole Hotel and in the MI Gardens, that were very hard to explain by normal transmission route. And one would have to conclude that the transmission in those situations was highly likely to have been past the pattern we're probably seeing in COVID. A disease that has that's able to exploit multiple modes of transmission, is predominantly spread by close contact, predominantly spread by infected individuals who are symptomatic. Symptomatic individuals are more likely to transmit than asymptomatic people, even though asymptomatic people can transmit the disease. And I think that transmission is occurring at close contact, and we see that in families. Most of the secondary transmission in this pandemic, and people are saying, oh, it's all occurring in these big crowds. It's not. A lot of the secondary transmission is occurring in households. And the success in China and in Korea and other places was offering people facilities to isolate. In fact, they were finding it very difficult to stop transmission in the household, and very often were asking the infected person to actually isolate away from the house because there was such secondary transmission. So in that situation, I think we're seeing that kind of close quarter spread amongst families. So sometimes we see these arguments, it is one or it's the other or it's this, and in fact I think that confuses people. The real issue is all modes of transmission can occur. We believe there's a predominant mode of transmission. We believe we know what the highest risks are, but all modes of transmission can occur, and the risks are always increased by the context you're in. If you're in closed spaces with others for a prolonged period of time, if you live in a multi-family house where no one has I mean, for example, sorry to go on here, but if we look at the conditions in somewhere like Sweden, Sweden has avoided a lot of secondary transmission in the household because many people in Sweden live in single family households or very small families in larger houses, whereas in Sweden, one of the problems they face with the Somali immigrant community is the Somali community in Sweden live in multi-family situations and often in some disadvantaged situations. So they had a much higher incidence of disease, not because the virus was different in them, but because the social conditions in which those people live allow the virus to transmit in those family groups. We saw the same in northern Italy, the multi-generational nature of houses. Why were so many older people exposed so quickly to this virus? Because older people live with younger people. It's a wonderful thing. The Italians should be greatly praised for the way you see multiple generations living together. I think it's a fantastic thing. But in the case of COVID, it meant a lot of older people became exposed to the infection within the household environment. I mean, older people aren't out partying, older people aren't going to the nightclubs. You know, they're not getting the disease. Older people are getting the disease at home or within the healthcare facility that they're in. And people are bringing that infection to them. So I think we probably need to move away from these polemics, these arguments of between science. I sometimes think when scientists clash, people get confused. When politicians clash, people get confused. When scientists clash, people get confused. We have to weigh all of the evidence, and we have to give people the clearest possible principles of how to avoid infection. That's what people want to know. People don't want to be scientists. No, you know, just tell me what to do and give me a good reason why that's a rational thing to do. So when we say wash your hands, maintain your physical distance, avoid crowded spaces, wear a mask in the situations where you can't maintain any physical distance, right? Simple rules. These rules, if you're sick, stay at home. If you're sick and home and you can't be isolated, please stay away from your other family members if you can. Be in another room. We understand that's not possible for everyone. So a very, very simple set of rules to guide your daily life, and everyone can be safe.
Thank you. There are follow-up questions to this already coming. So one is as well, is the virus becoming weaker as the time passes? And I'll read one. Do you think this is more contagious than previous viruses, for example, Spanish flu? Do you think it will last up to 2 years like previous pandemics, epidemics?
So the first question, sorry, say the first question again.
The first question is, does the virus become weaker through the time?
So that's a good question because I think we're getting better at dealing with this virus. So the virus that is circulating has been circulating the globe. We have 35 million reported cases so far. Almost all countries have been affected by this, and we're 10 months in. And we are in a completely different situation than we were in a few months ago. And the reason I'm saying this is because we're getting better at finding cases. So through active case finding, we're detecting cases earlier because we have better surveillance, we have better diagnostics, and that means individuals are either isolated quicker, they're put in clinical care quicker, and that leads me to the second point. If individuals are put in clinical care sooner, then they can receive the actual care that they need. Doctors are better equipped, trained, they have PPE, they have experience with dealing with COVID patients. We know that access to oxygen, checking oxygen saturation when somebody comes into a medical facility, providing oxygen, providing dexamethasone when someone is severe or critical, that saves lives. And so our mortality rates are reducing, but that's not because the virus changed, it's because we're getting better. And that to me is an incredible sign of hope, that we have tools right now to actually, help people. The other thing is that we are preventing infections in these vulnerable populations. As Mike has talked about when we were talking about the transmission, in addition to what we were explaining about how it spreads, another factor in this is what we call the dispersion factor. And it's a big fancy word that basically means not everybody transmits to somebody else. We are working with partners and estimate that between 10 and 20% of cases are responsible for about 80% of transmission events, which is why when we say that this operates in clusters and that it's the setting that is so important, if we allow this virus to spread in a setting that's an enclosed space and a long-term living facility, a prison, nightclubs, we in a way facilitate it. We give it the opportunity to spread between people who are singing or shouting or having long periods of time together. And so I think that's really important because, again, knowing that helps us do better at preventing it from happening. If we could prevent the virus from entering a long-term facility, and many countries are doing that because, unfortunately, in the beginning of this pandemic, some countries were really devastated by how many older people were dying in long-term living facilities. That is changing. We still need to work very, very hard to protect older people in that sense. But we are getting better at dealing with this virus, preventing amplification events, these super spreading events, caring for individuals, making sure that they receive the care that they need. And so I think that's why people may think that the virus is getting weaker, but make no mistake, this is a dangerous virus. There are more than 1 million people who have lost their lives, and the virus has a lot of room to spread. We know that the majority of the world remains susceptible to infection, and if we allow it to, it's in our hands. If we allow it to, it will spread. And many people, although luckily those many that get infected will recover, which is good news, there are people who will continue to die, and so we need to do everything that we can to prevent that.
Maria, you mentioned, and both of you were saying already that many people around the world are still susceptible to this virus. How do you know that?
Can I just before she takes, because there's one little thing on the previous question I'd just like to add, because I think it's important as we look into certainly the winter in the Northern Hemisphere. Maria's absolutely correct. Doctors and nurses are getting much better at treating. People are getting better at recognizing those worrying symptoms. People now know about, your oxygen level in your blood, and people can tell you that it should be over 95% and whatever. So I think people are getting, and people know that shortness of breath is a symptom that should take you straight to the hospital. So people are beginning to understand the triggers to move quickly, and that's great. But the system has to be able to react to that move. And having worked in emergency rooms myself, sometimes there can be war zones. Now, a very simple question to the listenership: where are you likely to get better care? Where are you likely to survive? In an emergency room full of patients, some mild, some moderate, some severe, completely overcrowded, with the ICU full, with the healthcare workers tired and stressed and just trying to get by? Or in a well-managed hospital where the number of cases coming in on a daily basis is reasonably low, and where the doctors and nurses have time to give each patient the maximum attention. And that's what we've kind of seen over the summer. There's much lower pressure in the system able to really look at each patient. So what we're saying in a sense is, if we can reduce that force of infection, the pressure that the infection puts on the system, then the system can cope. And it's not just that the system can cope and the doctors and nurses can cope, it means the care will be better. More people will survive. More attention will be given to each individual person. And that matters. That matters clinically. We've seen how absolute close attention, getting the best care possible, can make a huge difference in the outcomes here. So I think that's important for people to see, because we all contribute to that. It's not about each individual infection, it's about how the system is able to cope with all of the infections put together. And I would say to you that while intensive care beds have increased in countries over the last 6 months, they haven't increased to the level where they can cope with the major second wave, and that's what we need to avoid. Back to your question, sorry. It was
How do we know?
How do we know? Yes.
How do we know? Well, we know for lots of different reasons. People have heard me speak quite a lot about seroepidemiology studies, and these are studies that measure the extent of infection in the population as measured by antibodies. And antibodies develop in individuals who've been infected 1 to 3 weeks, maybe a little bit longer after they've been infected. And this gives us an indication not that they currently are infected, but that they were infected. And many scientists across the world have been really trying to push towards the development of seroepi studies done in emerging outbreaks and in pandemics, because it helps us really understand how far it's actually spread. So we are tracking globally all of the seroepidemiology studies. I shouldn't say all. I would say most of the seroepidemiology studies that are happening globally. And we are summarizing this. We have a database, we have groups that are doing literature reviews for us, and we're picking these up through peer-reviewed publications, we're picking them up through preprints and government reports and press releases, because so much of the results in this pandemic have actually come out through press releases. So to date, we know that there are more than 150 publications that are available on seroepidemiology. Some of these are peer-reviewed publications, about 70 of them are peer-reviewed, and about 78 are preprints. And then we have some government reports as well. And what we look in those is, what were the populations that were studied? And in some of those studies, they follow general population. They look at blood donors, or they look at leftover clinical samples from patients who visited a hospital. Some of them focus on very specialized groups, healthcare workers, for example. Some are conducted as part of household transmission studies to really understand the extent of transmission there. And so what we know from this is that the vast majority of these papers indicate that less than 10% of the population have evidence of infection. And in many situations, it's well under 10% in the general population. But in some populations that have higher levels of exposure, like health workers or some high-intensity transmission areas, they're higher. So it's like 20-25%, but it depends. So we have to be careful when we compare these, because they're not all done the same way. They're not done in a standardized approach. WHO is working with about 50 countries right now to actually use a standardized methodology to conduct these studies. We've written protocols, these core protocols, these templates that countries use. We work with them to adapt them at the local level. And then we help them run them. The studies are theirs to run. We actually provide the seroassay that they can use, so that there's the same assay that's used, so we can compare the results. It's almost like comparing apples to apples, as opposed to when people, groups use different methodologies, it's like comparing apples and oranges. So for us to support countries in using a standardized approach, when we get those results back, we will be able to compare them a little bit easier. So it all comes from seroepi studies. And then there's some statistics that are done, and some modeling estimates that are made. And there's some good reviews that are starting to come out. There's a preprint that's come out from a group that's very nice, that summarizes what I just summarized. So that's where that comes from. And these studies are being done all over the world. They're being done in high-income countries, low-income countries, in urban settings, and rural settings, and health workers, and slums. And so we are consolidating all of that to really help us understand this. And the results tell us that the majority of the world remains susceptible.
What else besides that? These studies also are telling us about antibodies. Have we learned anything else? For how long after a person has been infected can have immune system immunity build against COVID-19?
So this is a great question. We get this question a lot, and this is something we are learning about. You hear us say this a lot. We don't have all of the answers, and I know that's frustrating to some people, but this is something that we are learning, and we remain humble to this virus. And we need some of these studies to be finished to really help us understand. When you look at immunity, when somebody is infected, they develop an immunity, as I mentioned previously. We are looking at how strong that lasts and for how long that lasts. The best studies that look at this are called longitudinal cohort studies, and they follow the same individual over time. And it basically looks at that antibody level over time. And that, what we understand from those is that people who develop a response have mild disease all the way through severe disease. They develop an immune response. Even people who have asymptomatic infection seem to develop some kind of an immune response as well. How long that lasts, we don't have a complete answer to that yet. For the people that we are following over time, for several months, it's remaining a strong antibody response. That's good news. There are some studies that suggest there may be a slight decline, but we don't know yet. And so we need to reserve a complete answer on that until we know. But people do develop that strong immune response, and that is good. We have some clues from other coronaviruses. SARS, the first SARS virus, the MERS coronavirus, and then the human coronaviruses, the common cold coronaviruses, and immunity doesn't last forever. And so what we need to understand for this particular virus is how long it will last, and if it does decline, when will it decline, and what does that mean for a potential into the future?
Yeah, and I think we also need to look at not just whether infection occurs again. Because yes, there could be, certainly in any disease, there's a waning immunity over time. And that's why some vaccines you need a booster dose. For example, in yellow fever, you used to have one dose and then one dose 10 years later, because we didn't know would immunity last forever. But then over the years, we found out, well, actually, immunity does last, and you only need one dose in your whole life, and you're protected. Measles, you have 2 doses, and then maybe a booster dose later in your life. So each of these different things, the diseases, requires a different sort of pattern of protection. So, but also, very often is the case, even if you can become reinfected, the question is, what is the severity of your next infection? In other words, does your previous immunity give you a head start? And even though you get a bit sick, you might not get as sick. And that's the case with most infections, but there's also a syndrome of disease enhancement where your second infection can be worse than your first one, like happens in dengue. So in different diseases, you can have a different reaction to your second infection. That we don't know yet. What we hope is that second infections will be in the main milder and have less impact on the individual. But that's why we want to track, and there are a lot of studies out there that are currently tracking people who get a second infection to really determine whether that second infection is the same, is it worse, is it better, is it easier to treat. That's important. The other thing, I think, that we can't just look at the seroprevalence in terms of protection, because that really measures what's called your B-cell immunity, or the antibody-based immunity. There is another form of immunity, T-cell immunity, which is much more broad-based. It's a little bit less specific. It's more and more difficult to measure that in your blood, but it does give you a level of protection. It's almost like you have different levels of immune protection. You have your innate system, your ability just to react to the presence of a foreign body like a virus. And that innate system is what starts the basic response of inflammation and just saying there's an intruder alert, and the system goes on intruder alert. And then there is, well, find the thief. So you have the issue of the intruder alert goes off, there's a reaction, and then you go looking for the for whoever's broken into your house. If you're doing that in the dark, it's very hard to find. If you've got a torch, maybe you find them much more quickly. And that's, in a sense, having that previous immunity means those antibodies can go looking for the virus and put that virus out of commission very quickly. If you don't have those antibodies and it's your first infection, you've got to encounter the virus, develop the antibodies, kill the virus, and recover. Second time around, hopefully, or if you've had a vaccine, you're already attacking the virus from the very first moment. So I think it's difficult to measure some of the T-cell responses. Also, there is the concept of cross-protection. Yes. We know that with many, many viruses, there can be cross-protection by having a different strain of the same virus previously. You can get some protection. And also sometimes with completely different viruses. you can have some cross protection. And there are some anecdotal studies at the moment that are looking into, for example, previous dengue infection in places like India and Pakistan. Has that protected people? And has that protected people because they just generally got an immune boost and their system went on the alert, so when COVID came, their system was more ready? Or are there specific antibodies that are made against dengue or another disease that might have some impact on the coronavirus? So there's lots of intriguing ways in which our immune system operates, and we tend to oversimplify it for ourselves and for others, and I don't think we fully know the full story of the complex immunological process associated with this virus. But I think what we can say with a great deal of certainty is the vast majority of people still remain susceptible to that infection, and we don't know how long protection will last in those who've had an infection. Both of those mean we need to be really careful. We can't make any assumptions that 60 or 70% of the population is all of a sudden miraculously going to be protected in a few months' time. That's not a strategy.
Can I just say one point
Please.
to that, because this is incredibly complex? One of the things I think is the value of WHO is our ability to work with scientists who dedicate their lives to studying this level of detail. And so, and not just one scientist here or one scientist there. We work with scientists across the globe that have experience with the B cell, T cell response, seroepidemiology, virus kinetics, antibody kinetics, coronaviruses, influenza viruses, dengue viruses, and bringing that together to help us really understand this. This is complex stuff. We're trying to explain it because these are very important questions that are coming in. Is what does this mean for me?
We don't understand it all the time.
We don't understand it all of the time. We're
You had a
doing our
conversation
best.
between
Yeah.
two immunologists. You look for the guy that's not very smart.
Yeah.
I'm the not smart guy in that conversation.
I mean, we are doing our best, and I think Alex, you know this, and Mike and the whole comms team here knows we're doing our best to try to explain these complex topics. But I think it's also important for viewers to understand that it isn't just us sitting around talking about this. There's a whole network of scientists that we work with every single day. Whether we're on the phone with them or we're having video conferences, they're sharing papers with us, they're sharing results of studies that they are doing to help us break it down into questions that can be answered. But I think you've heard me say before, every question that we answer, we have 10 more questions that follow, because that is science. Science is a series of questions, it's a process that we answer, and then we ask more, and then we answer. And I am very grateful that we have so many partners that we work with to work with us to actually answer those questions. We don't have labs here, that we sit and do this, but we work with people who do. And for us, to be able to bring that expertise together drives it forward. And they have the same drive that we do to getting these answers. And so we're just really, really grateful, and I don't think we say it enough, to all of our scientific, technical, public health professional, academic, frontline worker partners for the work that they do.
Yeah. And could I just also say on that, because
Please.
for young women in science, yes, we have fabulous scientists like Maria and others in the house and in all of the institutions that Maria mentioned, but there still is an imbalance. We need more girls in science. We need STEM. We need girls to follow that STEM. Some of the finest, most dedicated scientists I know are women. We don't have enough yet. It's time to bust that glass ceiling. We need more girls in science.
I hope WHO, with walking the talk with Maria, our chief scientist, and other women in science, will be role models and calling for more girls to get into science.
Can I tell you, I have one of my favorite things is a little girl. We're diverting, but a little girl, a daughter of a friend of ours, drew a picture of me with a white coat on and said WHO, and it had a cape in the back. And it was so sweet, and she really inspired me. It was very sweet, and I've received messages of saying, I watch your press conferences with my daughter, and it's very, very special. And yesterday or 2 days ago was World Teacher Day, so we should give a shout out to the incredible teachers that are out there. Hello, Mr. Good Friend, my AP Bio teacher, and my parents are teachers, retired teachers.
Hello, Austin Egan, nice science teacher, Austin Egan.
We're just so grateful.
Speaking of science,
Science teachers. but all teachers, really, all teachers that give that confidence. And I'm very lucky, and we're very lucky. We had access to incredible education, and not everybody has that. So we need to improve access to education. We need more women and girls. Thank you for saying that, Mike. More women and girls in math and science and engineering, and girls, little girls out there need to know that they can do anything that they put their mind to.
Thank you. This was great motivation and call for more interest in science. You mentioned when you talk to other experts, you have a lot of questions, and there's a lot of follow-up questions on different things you mentioned. So I'll start how they were coming. Just you mentioned on immunity. We are also looking how strong it is, and that even people who were having mild or asymptomatic are developing some immunity. So does that immunity after, or we don't know yet?
Well, that's what's being measured right now. And so I don't want to give a concrete answer because I don't know the answer to the question. I mean, in general, we know people that have a more severe disease, they could maybe develop that immunity quicker. It could be stronger, it could be longer lasting, but that we don't know yet. And so we don't want to overgeneralize. But I think the point is that people do develop an immunity. And so that's a good sign. And that's very good for what we know about vaccine development. But it also, also want to add to this to say people still need to do, even if you have been infected once, there are people that are out there that don't know that they've been infected. They may have had asymptomatic infection. It's really important that we still continue to do all of the measures that are put in place. The physical distancing, the hand hygiene, the respiratory etiquette, wearing a mask, staying home if you're unwell, call your doctor, making sure that you improve natural ventilation in rooms, avoid the 3 C's, these crowded settings. All of that still remains. This is part of this new normal that we have, that we are working towards until we get through this. I think there's a lot that we still don't know. And we just need to do everything that we can to prevent infections. You've heard Mike and I both talk a lot about not fully understanding the long-term effects. And this is still something, every day we are learning more. Every day we are trying to work towards getting a clearer understanding of who and why some individuals have long-term lingering effects that affect their heart, that affect their lungs, that affect their brains, and why and how we can better provide support. So don't take the risk. Don't take the risk. Prevent infection, as much as you can. Do all the steps, do it all.
Thank you, Maria.
Just again on that point, I think it's important when we talk about people having a strong reaction. It doesn't mean they're necessarily reacting better to the virus. An immune response is not determined by how much you're shaking in the bed, to be honest, or how much your breathing is affected. There are 2 things that happen when a virus comes into your system. It replicates in your cells, and it can do direct damage as those cells burst open to release the virus. So basically the virus can directly damage tissue, and that can cause symptoms. The second thing is the immune system reacts to that, and it detects those intruders, it detects the damage, and it tries to put out the fire. But it's a bit like one of those sprinkler systems in a building, right? It may put out the fire, but it can do a lot of damage itself in the process. It's the lesser damage. So your immune system is a very complex system. It's set up there looking out for danger from all kinds of different viruses, and it's basically on the lookout the whole time, and it's on a hair trigger, and it reacts. And sometimes it can overreact. So it reacts to the virus, and it starts to deal with the virus, and then it triggers these other inflammatory cascades, and it kind of over-responds, and your system goes into overdrive. And in fact, in many of these cases, and in many of the severe cases of COVID, it's not the virus doing the damage. It's the immune response to the presence of the virus that's causing the inflammation in the lungs or driving that inflammation, and then the inflammation in the cardiovascular system that we're seeing as well. So when we see those oxygen levels drop really quickly, that's not necessarily due to the direct virus damage. It can be due to the inflammatory response. And we see this more and more. You've seen that syndrome in children, hyperimmune syndrome in kids as well. We've seen that. There are other diseases that humans get that are considered to be driven by that sort of hyperimmune response. We see a whole range of autoimmune diseases that we see more and more of, like rheumatoid arthritis and other things, where we know the body is reacting to its own tissues. So we see that the immune system can go wrong in some of these chronic diseases In acute infections, equally, the body can miscalculate how much response do I need. Because the body is kind of saying, I need to get rid of this thing, and it throws the kitchen sink at it. And sometimes the body miscalculates how much response is needed and overdoes it. And that's why dexamethasone and other drugs are now being used, because in fact dexamethasone doesn't kill the virus. Dexamethasone actually damps down the immune system. It reduces the inflammation. And that's what doctors are trying to do, is to get the patient through the process so they develop their own innate immune response without overreacting. And that's why we're getting better at getting patients through that system. So I think it's important. Someone can have no symptoms and have a very strong immune response. Then they never know they were infected. So if you were an asymptomatic person and you got your blood tested and it shows you're positive, you're positive. It doesn't mean you had a weak response because you didn't have symptoms. That's not the case at all. The symptomatology is not that related to the level of immune protection you would have after the fact.
Thank you both. I don't know where to start with follow-up questions. One is maybe we can respond quickly on the immune system. How can we boost immune system but without making a harm?
I'm going to say all the things that we don't do here right now in WHO over the last 9 months. Sleep healthy, eat healthy, reduce your stress levels. In fact, stress, and it's been shown very clearly that all of these affect white cell activity and stress, fatigue, poor nutrition, they all affect your immune system. Your immune system is one of the most complex physiologic and biochemical systems in the body. As I said, it's on a hair trigger, so it doesn't need much to flick it into, mismanagement mode. So it is very, very sensitive to your general well-being. It's very sensitive to your general level of health. It's very sensitive to your general level of well-being and mental stress. So yes, the best thing everyone can do is try and get those things right, and they do no harm. Beyond that, in terms of immune boosters and all of that, I don't think we have any specific therapies that pre-boost the immune system. We do have the therapies, for example, now like the monoclonal antibodies or polyclonal antibodies that are coming on stream, which may be able to give people in the early stages of infection a boost of antibodies, a cocktail of antibodies, concentrated antibodies that might be able to help people who may develop more severe disease later. But no, I think the general exercise, rest, health, and getting enough sleep and avoiding as much stress as you possibly can.
Thank you. Several viewers.
Anything else there? No.
Yes.
I'm going to try and take my own advice now this evening. Yeah.
Prescription.
Get more sleep.
Well,
So
I can hear my parents saying
Yeah, I
that to
know.
me right now.
all the time.
Yeah.
So we received a lot of questions from Twitter, LinkedIn, Facebook. All viewers would like to hear more about the studies and research you mentioned on reinfection and also on long effects from COVID. Is WHO generating some data, and what is the available research, and what do we know so far?
So I'll start with the reinfection. So we have a group that is really focusing on reinfection. There are several studies that are underway. I'm going to look at the countries because in areas around the world, we have India, Ecuador, the Netherlands, Belgium, the US, Hong Kong have done some studies looking at reinfection. And they're measuring this through laboratory confirmation with sequencing. So in these examples, these are case reports. There still aren't very many of these right now, but there are more that are being identified through sequencing efforts. So essentially, they had a sequence from the first infection, and then during the second infection, they took a sequence again and noticed that it's a different virus. So we are looking at how we're working with many organizations on this because we need a unified front on what we classify as reinfection. We're working with ECDC and US CDC and all of these labs to look at, it's not only does somebody else test positive for SARS-CoV-2 again, but if they can sequence that virus, is that virus different? And there's ways that you look at it because all of these viruses mutate, they change. These are natural changes. And there's a certain pace and rate at which that happens, whether it's very, very fast or very, very slow. SARS-CoV-2 mutates on the slower end of the spectrum. And so if one reinfection was on day 1, let's say, the first infection was day 1 and the second infection was on day 100, let's just say, you can look at how many changes were happening and determine if that's like the natural evolution or if that's really, it is a reinfection, and the sequencing helps us do that. So it still seems to, we're still looking at case reports, and it isn't happening on the wide scale that we are aware of, but more people are paying attention to it and looking to see if it happens. So this tells us that it can happen, but we go back to the immune question. We go back to that immune response. We do know that the majority of people, are developing, 90% of people will develop that immune response within that first few weeks. And so that is a good sign. We need to understand in these instances of reinfection, why did that happen? Did somebody not develop an immune response the first time? Did their immune response reduce or wane, we call it, allowing for a second reinfection? So those are the types of questions that we're looking at. But we have a working group that's specifically dedicated to this to help us better understand what it means on a population scale, globally.
Mm-hmm. On the issue of the long-range effects, because I think it's important to reflect on that, and certainly many people who have COVID, even the milder form of disease, can have extended periods of fatigue, persistent cough. Some have persistent shortness of breath, and whether that's true shortness of breath or just the uncomfortable nature of the condition remains to be seen. Headache and sometimes joint pain. So it's a general feeling, like a hangover feeling, that may go on for weeks and months and may affect people's exercise tolerance. And that's just a long haul effect. And that's tough. And there are many people out there with that sort of post-COVID type syndrome, which a lot of people are suffering with. And then beyond that, there's a smaller group of individuals, and some of these are young people, who have long-term organ damage associated with COVID-19, lung damage. But what the virus tends to do when there's that reaction deep in the lung is the alveolar sacs. What you have in your lung are little air sacs, millions, billions of these little air sacs that are very close to the blood vessels, and the oxygen goes back and forth. The oxygen goes into the blood, and the carbon dioxide comes out, and we breathe out carbon dioxide, we breathe in air, and we recycle that, unlike trees who do the opposite. That's why we have this wonderful cycle in the world. The trees take in the CO2 and pump out oxygen, and we take in the oxygen and pump out CO2, and so the world continues. And in that sense, these little sacs can become damaged, the linings of them, but also the blood vessels around them can become inflamed. And what you see on the CT scans is something they call ground glass opacities, really small, little fine opacities, not like a big pneumonia. It's just as if there's this peppering of the lungs with all this little minor damage. But if you add up the little pieces of minor damage, that can add up to a lot of damage in a lung. So people can have long-term lung effects. We've also seen long-term heart implications. In some people, again, that hyperimmune response. The virus doesn't go out into the system per se. What happens is the immune response to the virus in the lung can extend beyond the lungs. And we've seen inflammation of blood vessels in different parts of the body and even into the heart. And we've seen certainly in studies in Germany that there can be changes to the linings of the heart and changes to the muscle in the heart that go through months, and that's even again in young people, and that can affect their cardiac function. We've seen fatigue, exercise tolerance decrease, and the ability to process oxygen in the lungs. And studies here in Switzerland have shown again in younger, milder and moderate cases, persistent loss of exercise tolerance. Now that doesn't mean it won't recover, but generally speaking, if you had a moderate or severe case of COVID, and even if you're young, the recovery period takes quite a while. It can also have effects on the brain, and it can cause seizures and even ongoing risk of seizures afterwards, and that's even in young people as well. I'm not trying to paint a picture here. The vast majority of people get this disease, feel awful for a few days and recover and get on, right? But that's not everybody's story. And those severe cases and those severe outcomes are not only in older people. They can happen in younger people, they can happen in children. So it's really important that we take those consequences seriously and that we support the survivors, because they're now struggling with the second problem. They've had COVID, they've gone in, they've fought, they've got through it, and now they're left in a very tough situation. The world gets back to normal and they're left there thinking, well, what about us? We can't work, we don't have energy. And that's a lot of people. So we really do have to look out for these people. I think there's a lot we can learn on how to treat the after effects better, and that's why we have the studies underway. And health systems are going to have to cope with those long-term care needs of people who've had more severe and long-term problems associated with this disease.
Can I follow up on that? Just
Please.
to say, we have reached out to different patient groups to really better understand and to hear from them what they're dealing with. And Mike has outlined all of the different complications that are happening, but we also have to remember that they're also, as they are going through this, what they've asked for from us is help with recognition and saying that this is a real thing. Dealing with long-term effects and this long COVID syndrome is really true, and it's happening, and we hear you loud and clear, and it needs to be recognized. They're asking for rehab, support in rehab, and better understanding, what is happening to them and helping them through this, through all of the different complications that are happening, and research, because we need to better document what is actually happening, because that will help us actually tailor the type of rehab that can be provided. But I do also want to address the mental health issues and the stigma and the depression. This is incredibly hard because, there are people that are still dealing with these lingering effects, and this is very difficult. They can't work, they can't exercise, they're having chest pains, they can't breathe properly. And we need to support them. And I've seen a couple of messages on social media of people just saying they want to give up. Don't give up. Please don't give up. Please don't give up. We are learning more about this every day, and we are learning different ways that we can provide support to you. We're working with our member states to figure out the best ways that can actually provide that. There are studies that are ongoing. Get involved if you can. Join some of these cohort studies that are starting up. I know of several that are underway. We need more of them to be done. We need more of them across different countries, not just high-income countries, but low-income countries in urban areas, rural areas. We need your help. And so please don't give up. We hear you loud and clear, and we're working very hard to ensure that we give you the support that you need.
Yeah. And could I also say then, when we talk about, we end up in these sometimes difficult arguments around whether we should just let this run and get this over with and then get on with life. And, we don't live in a land of no consequence. What we're trying to do with partners is to buy time also, is to control this disease as best we can with the measures we have now, push infection down to the lowest level so the fewest possible people get this disease. And what does that give us then? That gives us more time to learn how to treat the disease better. That gives us more time to learn how to treat the recovery better, learn more, and find out more so we can treat better, treat earlier, reduce the consequences, deal with the consequences of disease, learn how to better protect high-risk populations, learn and develop the most effective and safe vaccines, and ensure we take the time to make them safe. We get more time to make vaccines safe if we're in control of the virus. The pressure to bring the vaccines out because everyone is scared because the numbers are going up again, we can control that. If we take it laissez-faire and say, okay, look, let's just let everyone get infected, then we're going to pay a price, and there'll be a lot of that, use that terrible word, collateral damage. And certainly I do not accept, I personally do not accept that older people can be sacrificed in this way. This is not correct. This is not what we are as a society. So we have to protect them, yes, but at the same time we can't just say, let this rip. We have to do what we can. Now, having said that, we also have to be cautious, because measures and those, and I'm not talking here about lockdowns, I'm talking about good surveillance, I'm talking here about cluster investigation, I'm talking about communities that are empowered to prevent infection, I'm talking about good care in hospital. We do know these huge, long-term lockdowns are not, in that sense, the best solution, but countries sometimes face no choice. But lockdowns, in a sense, are when you've nothing else you can do, but there's lots we can do. So I do think, I do hear people when they say these lockdowns and all of this is very economically damaging and we're doing damage to the health system and the education system and all, and I accept that this is not a no consequence effort. We need to find that balance. We really need to find that balance between stopping this disease, giving us the time to develop the measures we need to save lives, accelerate recoveries and prevent the disease, and minimize the effect on society. And again, I just do not want this to turn into another political football, another polemic around one way or the other. Unfortunately, fortunately in life is never like that. It's not binary. It right and wrong and left and right and good and bad and you know, we've turned this into some kind of simplistic thing. You're either for mass or you're against mass. You're with me, you're against me. You're my enemy, you're my friend. Life is too complex, and I don't think biology is that simple. And I do think we need to, you know, we need to take a pill and get real here. It's not either or, it's both. There's no trade-offs here. Nobody wants, I don't want lockdowns. I mean, I'm away from my family. I know now if I go home tomorrow, 14 days quarantine one way, 14 days quarantine the other day, to see my kids is going to take me 29 days for one day. 29 days. Do you think I like this? Do you think we want this? No, so we need to be rational. And those measures that restrict society need to be kept to the minimum that is effective in dealing with the disease. And I would certainly like to see a lot more investment in our testing, tracking, tracing, cluster investigation, in supporting people to isolate themselves at home. If people who were sick stayed at home and were supported in doing that, and if their contacts stayed at home and were supported in doing that, we could break the back on this disease. And we keep avoiding that elephant in the room. We really do. And we need to get back to have a big discussion about that in the coming weeks.
And we need to learn from each other. So exactly what Mike is saying, countries are showing us that that works. It's not just us sitting here saying, please do that. Countries are doing this and it's working. I mean, if you look at, I spent 2 years living in Cambodia, working, I was doing my PhD on H5N1. Everything about active case finding, contact tracing, all of the, I mean, the public health system that is in Cambodia today is built over decades. The system that's in Thailand and in Vietnam and in China and in Japan and in so many different countries is built over time. And that workforce that is in place is being put to good use. These countries have shown that they can bring this virus under control. And they're getting their societies back online. That's how you get to economic recovery, is to control the virus. And it is being done. And we need to support, as Mike has said, we need to support countries that didn't have this in place. And unfortunately, many countries, many high-income countries, did not have this system in place. They're working very hard to get it online, but we cannot emphasize enough that active case finding, if you can find cases, if you can't find all the asymptomatic cases or the subclinical cases, focus on your symptomatic cases. Even there, that's a good start. Then you do your contact tracing around them. You will eventually catch up, and you will pick up those individuals who are asymptomatic and pre-symptomatic, and they will already be in quarantine. This is what breaks chains of transmission. Your testing capacity, the testing capacity that has grown tremendously across the globe, getting those test results back quicker helps you take public health action. This is what works. This is what will get societies back on track. This will help essential medical services get back on track. And so we're not only saving people from COVID-19, but we're preventing other people dying from preventable reasons. And I think that those are the things, I think that's why you can hear our frustration in our voice right now, because it's not just an academic exercise to say, do case finding, do contact tracing. This works. If you don't trust us, look at Cambodia, look at Thailand, look at China, look at Japan, look at Australia, look at New Zealand. I could go on and on. Please, learn from each other. Whatever works for you, find your motivation, find whatever it is that works for you to get this done. We have so much that we can do, so many tools that we have right now that work. And we need an enabling environment, not only for governments to be able to do this, but for people to follow the rules that are put in place and the recommendations that are put in place, I should say, and that communities can support each other, and that hospitals can treat patients that need to be treated. So there's just a lot that we can do right now, and all of this helps prevent infections, and it saves lives.
And the rest of my case, you see why we need more women and girls in science, huh?
Agree. We are running out of time. There were a lot of follow-up questions on the rates of how many patients are having lung effects, how many people get reinfection, how long is the period between the reinfection. Can we give a short answer to these questions?
Yeah, we don't know.
Yeah.
There you go.
Yeah.
We don't know.
We're learning.
We are still learning.
Yeah, we're still learning.
You also, my message here is those who haven't been infected or they don't know they have been infected, we still need to take care and practice, do it all the measures, but also people who have been infected, they also need to continue practicing these measures? Because someone is asking if is there someone immune to this virus?
Yeah, it's very unlikely in your first couple of months after you've had the disease that you will get reinfected. That's for sure.
Yeah.
But that's no reason for complacency. And again, we're showing solidarity with others. Why would I then take my mask off or close social distance because I'm sending a bad signal to everyone else? Because no one else knows I was infected before. So no one else knows that. So if they see me going into a crowded space and I'm not wearing a mask and I don't sanitize my hands, is that because I really don't care or because I'm already immune? Do I have to wear a big sign, I'm immune? Or do I show solidarity with the other people who are not infected to say, you know what, we are in this together? So I don't think it's a reason to disengage in the behaviors, but I do think there is an element of protection, and I think it will last for a significant period of time, and I do think potentially that a second infection might not be as severe, but that I'm saying I think it might not be.
Right.
Nobody knows.
We don't know. And this is the humility we have as scientists, as public health professionals, as people who are trying our best to try to absorb as much information, get these studies done. But I think everybody needs to accept and acknowledge that we don't have all the answers yet. And so don't take the risk. Do all of the things that work. Do all of the things that will keep yourself safe, keep you safe, and keep your loved ones safe.
And again, you may or may not have 100% confidence in what your local authorities are doing or what your government is doing. People live in different situations. People live in different places where governments have taken this more or less seriously, okay? But at the end of the day, it's still a virus, and you can still do a lot to protect yourself. Make your own plan. Make your own plan. Protect yourself, protect others. You can do that. If the government supports you in that, fantastic. That's what we want to see. Some situations, governments aren't doing that. Communities are on their own. Communities can do an awful lot. I've seen communities for the last 25 years in the field, in the most horrible of war zones, taking ownership of their situation in the most extreme of circumstances. In some cases where the government was trying to kill them. The government was actively attacking its own people, and they have found solutions to the most complex problems. So communities, to me, are the most powerful thing in the world. So I do think, even in situations where you don't perceive that your government is doing everything it could, there's still a lot that you as communities can do. There's still a lot that community organizations can achieve, even without a government doing all of the right things.
And I have a specific assignment to the viewers. One specific assignment. I said this a couple of weeks ago about making a plan. You just triggered my memory on this. Make a plan to know what you need to do if you think you are infected. What do I need to do if I think my child is infected, if my husband or my wife or my whatever is infected? What do I do? Where do I get a test? Who do I call? What are the steps? Write it down. Have a plan. Because if you're doing that when you think you are infected, you would be quite heightened, but make a plan. And if you don't know now, figure it out. And because I think that will help us through the fall, especially in the Northern Hemisphere as the fall comes in and we may have influenza circulating as well as COVID. Make that plan now for yourself and your loved ones. That's an assignment that I give to all of you.
Thank you very much, both. We are running out of time. Just to remind our viewers that as well as in WHO, we are not immune to this virus, and the reason we are not wearing a mask at the moment, even though we are in indoor space, is because we are physically distant over 1 meter apart. Also, we are having good ventilation, and we can open... It's freezing here, and we can also open windows still. So I thank everyone who is watching us and for all your great questions. I will just list some of the countries. The list is long. Canada, Iran, the USA, Nepal, Uzbekistan, Italy, Germany, Peru, Saudi Arabia, the UK, Benin, Malta, Egypt, Nigeria, Cameroon, Pakistan, Brazil, Bahrain, Turkey, Morocco, Rwanda, Bangladesh, Lebanon, Spain, Poland, and many others. I thank you both for your time, and please stay safe until next Wednesday. We'll answer more of your questions. Thank you.